So huge conference, lots of trials. I was not able to follow all of them, but I'll just mention a couple of them that I found interesting. Of course, the MARIPOSA study, the overall survival data was presented. So as you know, for first-line EGFR, we have 3 options now. So we have Osimertinib single agent, Osimertinib with chemotherapy, which is the FLAURA2 study, and now MARIPOSA study. So it's hard to choose between those 3 options because we did not have survival data for the last 2. And also there are other factors like patient-related factors, adverse event-related factors. But bottom line is now we have overall survival for MARIPOSA. Hazard ratio was 0.75. Importantly, there was another study looking at this combination, but from an adverse event perspective. So skin toxicities are very common, unfortunately, and this COCOON study was recently presented here, and it shows that dermatologic management, if we act proactively, this preventive management actually can lower the adverse events significantly. But even then, with this advanced management, grade 2 side effects are 34%. So this is an important aspect that we have to take into consideration. Some of the other studies that I found interesting, Crystal 7 was presented. So this is a study, single arm, combining Adagrasib with Pembrolizumab for untreated KRAS G12C-mutated patients with PD-L1 more than 50%. So in this study, PFS was 27.7 months. Of course, single arm study, we have to take that into consideration, but it is a significant data that was presented. Of course, when you combine a TKI with immunotherapy, side effects are going to happen. So in this study, LFT elevation was a major reason, and almost 50% of patients actually had to dose reduce, and almost 70% had to have interruptions. So I think all of those kept aside, I think it's promising to see that KRAS G12C can be treated with a targeted therapy in the first-line setting, and I'm looking forward to seeing other studies, phase 3 randomized studies on this subject. Another interesting presentation was updated overall survival for LAURA study, which was adding EGFR inhibitor Osimertinib after chemoradiation. So interim OS analysis had not shown the benefit, or like it did not show significance, but now we have overall survival data showing that 58% versus 54%. 58 months versus 54 months. But one thing I need to mention is that patients who were on placebo, 80% of them actually ended up getting a 3rd-gen EGFR TKI. So that could explain why the overall survival is not like very different between 2 arms, because patients on the placebo arm actually ended up getting 3rd-generation EGFR TKI. One other study I would like to mention is the ADRIATIC trial, which was adding durvalumab after chemoradiation for limited-stage small cell lung cancer. In this conference, the results presented for disease recurrence. So intrathoracic disease recurrence was not different between 2 arms, but extrathoracic, including CNS, it did favor durvalumab, which is another support for this study.